I see some more folks are starting to join us. Welcome and thank you so much for being here. We are going to be getting started in just a minute, and I'm going to be going over all of the items that you see on your screen as some housekeeping items. Okay. The time is now noon, so we can go ahead and get started. I'm going to stop sharing my screen, and then Dr. Townsend, you should be able to share on your end. Um, Thank you, everyone, as I said, for being here today with us. So, my name is Tracy Summer. I'm going to be helping to facilitate today's webinar. If you haven't already done so, please feel free to put your name and introduce yourself in the chat. It helps us to have an idea of who is online today with us. If you have, thank you so much and welcome. We really appreciate everyone being here. As I mentioned from the start, today's webinar is hosted by Max for Moms. And for those who are not familiar, that's the Maryland Addiction Consultation Service for moms, which supports our maternal health care providers with questions about treating their patients who are pregnant or in the postpartum period with questions about addiction treatment or pain management. And all of our services are free. We have phone consultation for clinical questions, assistance with finding resources for addiction or on behavioral health information, education and training, such as today's webinar, and we have our echo clinics. Please feel free to reach out to us anytime, and we will put our information into the chat. Some quick housekeeping items. We will have time at the end for questions. So if you do have questions, please feel free to put that into the chat. A copy of today's slides and the recording will be uploaded to our website within 1 week from today, and the slides will be sent to you by email after today. The credit process. Today's training is offering one CME and one social work CEU credit. To get credit for today's training, you must be online for the full duration and you must complete the evaluation survey within 7 days from today. That survey completion, again, is required in order to get CME or CEU credit. Immediately at the end of today's webinar, you'll be able to log into your OASIS portal to access your evaluation survey. Once you complete that survey, you'll be able to download your CME or CEU certificate directly from OASIS. It will also be emailed to you from OASIS. I'm now happy to introduce our presenter for today, Dr. Courtney Townsell. She's one of our Max for Mom consultants. And Dr. Townsell is a tenure track assistant professor and the director of perinatal research in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of Maryland. Dr. Townsell is dedicated to the full spectrum of maternal fetal medicine with a particular focus on perinatal substance use and abuse. She serves as the MFM lead for the support practice and is a consultant for moms. As a clinician scientist, Dr. Townsell has expertise in clinical and translational research. Her current research program centers on placenta transport and metabolism of opioids, strategies for preterm birth prevention, and addressing severe maternal morbidity and mortality. Her work is supported by foundation funding and NIH grants. In 2024, she was honored with the Robert Wood Johnson Foundation Harold Amos Medical Faculty Award, a prestigious 4-year career development award. Additionally, she is an innovator holding 2 U.S. patents for a medical device aimed at reducing preterm birth. Dr. Townsell actively contributes to the academic community as a member of several national and international boards and committees, including the editorial board of the journal Obstetrics and Gynecology, the ACOG Fetal Alcohol Spectrum Work Group, and the Diversity, Equity, and Inclusion Committee for the Society of Reproductive Investigation. Thank you so much, Dr. Townsell, for being here today with us. I'm now happy to pass it on to you.
Thank you so much, Tracy. And it looks like we have a great group of folks here, a good number of folks. And I just wanted to kind of just foreshadow the talk today and just say that I want to provide some strategies today and just kind of a way to think about how we approach pain management for our patient population. And so we'll talk a little bit about that. So today, for this presentation, we'll focus primarily on postpartum pain management for people with substance use and substance use disorders. So some of the learning objectives will again recognize effective pain management strategies for postpartum people with substance use and opiate use disorders after both cesarean and vaginal births. We'll look at benefits and risks of opioid-sparing strategies for this patient population. I'll try to highlight and touch on multidisciplinary collaboration in managing patients with a substance use disorder in the postpartum period. And again, identify some emerging guidance for postpartum pain management for patients with substance use and opiate use disorder. So I just wanted to talk a little bit about some of the barriers, clinical barriers for clinicians and for patients. I think a lot of the issue around managing pain in this patient population has to do with some mistrust, whether that be mutual or one-sided. I think there's two ways to look at this. I think from the patient perspective, there has been historic stigma, discrimination, a lot of labeling, and historically some undertreatment, and that could be twofold, right? For undertreatment because we're not sure how much to give, or undertreatment because we're concerned we're giving too much. And we also know that marginalized communities are even more disadvantaged when it comes to adequate treatment and adequate pain management for their substance use. Again, for the clinician, I think a lack of education around substance use disorders, particularly opiate use disorders, and how to manage pain in that patient population has been an issue. It's not something that has standardly been taught at the medical school level or sort of at the residency level. And so you just may not be comfortable managing patients with this complex pain history. There could be some bias against patients with substance use disorders or opiate use disorders, might feel manipulated or just have some fear and avoidance. And so I think there's a lot of reasons why we haven't quite gotten this right, and a lot of reasons why, there's still some misconceptions. So when we think about any care that we provide, we want to think about the level of evidence for, a heart attack. We know, we want to think about oxygen and sort of providing aspirin, and there's like a standard way that we approach all of those types of patients. And I think when we think about patients with a substance use disorder or opiate use disorder, we really just don't have sort of this evidence-based approach. A lot of the literature that we have are sort of case reports, case series, committee opinions, and we don't really have a lot of, randomized controlled trials when it comes to this patient population. So a lot of what I'm going to offer today is really evidence informed and kind of retrospective cohort studies because we really don't have the level of evidence that is necessary. So I'll talk first about just the pain experience of birthing people, specifically with opiate use disorder. We'll focus a lot on opiate use disorder because it's one of the more prevalent, more common substance use disorders that we encounter, but it also is directly in conflict with how we manage pain postpartum. Such that we give, opioids for that pain management. And so I definitely want to address that. And so there's two studies that have looked at the pain experience of birthing people with opiate use disorder. This one particularly looked at patients taking methadone. Patients had vaginal births and cesarean births in this study. And essentially what they found from this study was that there really weren't differences in pain scores. So during the laboring process, there weren't really differences in pain scores at that point. But patients taking methadone did seem to have longer admissions for vaginal delivery and delivery to discharge. They also tended to have higher pain scores in the postpartum period and required 70% higher oxycodone intake during that postpartum admission. The same group also looked at patients who were taking buprenorphine compared to control patients. Again, patients underwent a vaginal birth or a cesarean birth in this study. And what they found again was that there weren't really differences in intrapartum or laboring pain scores, but in the postpartum period, patients tended to have higher pain scores. And again, this patient population also required higher oxycodone intake, about 47%. So slightly lower than the methadone group, but again, higher than the general population. And so this was another study looking at pain experiences for birthing people, again, with substance use disorders, opiate use disorders. This is done by a colleague and myself. And this was a retrospective cohort study. We looked at patients with a history of opiate use disorder or chronic pain. We often have patients who are dependent on opioids, which can complicate how we care for their pain postpartum, or because of a chronic pain history, or we have patients who have misuse in the past and are chronically maintained on opioids. And we looked at patients in three groups: opioid use disorder on medication. We had a fair amount of patients who had a history of opioid use disorder who were observing abstinence. And then we had a group of patients who had a history of chronic pain and that were using opioids to manage that pain. And again, this is a smaller study, so about 69 patients. And overall, what we found is in this cohort of patients, the 69 patients, an opioid prescription was actually only given to 21% of all of the patients. 6.5% after a vaginal birth and only 52% after a cesarean birth. And so when we think about a C-section, I think we know that the majority of patients will need something for that high level of pain. And so to see 52% was pretty interesting to us. There weren't differences across groups, though these are small numbers, in terms of prescriptions for patients on medication for opiate use disorder, observing abstinence or chronic pain. We did see sort of a stepwise increase for patients who, when we looked at the opioid prescription size, it was much higher in patients with chronic pain compared to those who had opiate use disorder maintained on medications. And again, the other thing we looked at were refilled prescriptions. And so of patients who received an opioid prescription, about 40% of those patients required a refill. And so that was something that we also wanted to be cognizant of. So some things that we wanted to just kind of take from this study. So the refill rates for patients with opiate use disorder and chronic pain for our population, this was back in the state of Michigan, were about 2 to 4 times higher for vaginal cesarean births than for the general population at the same institution. So that was just something to kind of keep in mind. And then again, overall opioid prescribing rates for patients with opiate use disorder and chronic pain after cesarean births were much lower than for our general population. So again, we saw about a 52% rate of opioid prescription, but in our general population, we saw an 80% rate of an opioid prescription. And we wanted to really understand why this was happening. Was this related to systemic bias? We certainly have patients who don't want opioid prescriptions, don't want to take opioids in the postpartum period. And so could it be patient-led? There are many patients who worry about having those medications in their home or having access to them. And so what we really wanted to understand was, what is the patient perspective on this prescribing? And then also how, at the time, we were also rolling out sort of an opioid sparing protocol. And was that impacting pain and pain scores? And so the next thing we did was talk to our patients. And so we have this nothing about us without us. And I think this is really important as we embark on research. We as clinicians have our sort of perspective of the question that we want to ask, but it's really important that we get the patient perspective as well. And so we did a qualitative study. This was a phone survey to assess postpartum pain experiences of people with prenatal opioid exposure. So this could be patients with chronic pain or opiate use disorder. And again, there were 18 patients that we spoke to. The majority were non-Hispanic, white, multiparous with Medicaid insurance. And of the group that we spoke to, those who underwent a vaginal delivery, none of those patients received the opioid prescription. And again, about 50% of patients with a cesarean birth received an opioid prescription. And I just wanted to highlight a couple of representative quotes from this study. So we had patients who had a vaginal delivery and reported low pain scores. Patients in this group thought that non-opioid medications were sufficient to address their minor pain. These patients were patients who took buprenorphine, the two patients that we spoke to. So Tylenol was helpful for one of the patients, and I did not have a lot of pain, the other patient reported. In our vaginal delivery group with higher pain scores, they felt like a range of alternative pain remedies was helpful, but didn't always or entirely address their pain. And again, these are two patients who took buprenorphine with naloxone. One patient used cold compresses and tucks, and said that there might have been an appreciation that something else in addition to that would have been helpful. And the other patient felt like once they had their baby, their pain was less important, and that they wanted pain relief, but was less heard once the baby was born. And so that was just something that was elevated in that group. And then when we looked at our cesarean birth group, again, patients with lower pain scores felt like what was administered at the hospital was helpful but temporary. So the epidural was helpful. This is a patient who was observing abstinence. And then the anesthesia tap or the TAPS block, with some institutions utilize, was helpful, but that patient noted some leg numbness and difficulty after that TAPS blocks. And then we have the cesarean birth group who had high pain scores. And really, for that group, prescription medications were helpful for their intense pain. And really, for them, again, doctors prescribing the right medications and pain medications were the most helpful for patients with high pain scores. The other interesting thing is that we spoke to this patient population and asked them about their risk of opioid overdose um, after delivery. So the biggest, I think, concern from a clinician standpoint is if I prescribe these opioids, am I increasing the risk of an opioid overdose? And we know that opioid overdose is one of the leading causes of maternal morbidity and mortality. And so when we asked 10 of these patients about their personal risk of opioid overdose in the postpartum period, every single one of them reported that they had no risk at all. 100% of them said they didn't think that they were at risk. 50% of them reported having access to a Narcan kit or naloxone kit at home, and about 80% of the patients reported knowing how to use the Narcan kit. And again, amongst that group, 50% thought the Narcan kit was important and 50% thought it wasn't important. And so I think making sure that we as clinicians educate patients, make sure they have access to Narcan if we're concerned, and then make sure they know how to use the kit. All of those things would be really important as we're thinking about managing pain in the postpartum period. And so this is just a quick example of what we began to give patients, some information about accidental overdose and overdose during pregnancy and the postpartum period. It just gives kind of some statistics. A lot of this, the postpartum deaths and pregnancy-related deaths are related to overdose. And then on the other side, we just wanted patients to understand how to use this Narcan, the type that we administered. And there's like a little video that they could watch, and a support person could also watch. And so I want to shift gears a little bit to thinking about not just the patient perspective at these single institutions, but thinking more broadly. In general, when we take care of patients, we know that postpartum opioid prescribing has really contributed to the opioid crisis. We know that in general, our prescribing as clinicians has contributed to this crisis. But I think it's important to know that there's a recent study by one of my colleagues on those other studies is that 1 in 75 patients who has a prescription for an opioid after delivery has persistent use 1 year postpartum. And so being judicious in how we prescribe and who we prescribe and some of these risk factors, knowing that one patient out of 75 could be persistently using opioids after their delivery is important for us to consider as well. We don't want to, create issues. And so one of the things that we also looked at is variation in postpartum prescribing. So again, this is when I was in the state of Michigan, and the blue is vaginal deliveries, the yellow is cesarean births, and you look at the hospitals, right? And so each on the x-axis, each of these numbers represents an individual hospital, And on the y-axis, you'll see kind of like the size of the prescription. And so across hospitals, there's a lot of variation in prescription size after a vaginal delivery or a cesarean delivery. And again, just to note that after a vaginal delivery, many patients were receiving opioid prescriptions. And so this variation really represented an opportunity to improve pain management and how we address pain management in the postpartum period. When we looked nationally as well, so beyond the state of Michigan, we wanted to understand what was happening, across the country. Again, there seemed to be pretty wide variations nationally in opioid prescribing in the postpartum period. So when we sort of made the Northeast the reference, the Midwest almost double prescription filling after a vaginal birth in the South and in the West as well. And then again, after cesarean birth, there was almost double again in the South and the West and in the Midwest in terms of prescriptions for opioids after delivery. So one of the things this kind of led us to think about was creating some sort of clinical practice guideline or CPG. And again, we with the hopes to reduce opioid prescribing without compromising pain management for patients. And so just wanted to give a little bit of information about this analysis. So this is something that came out in 2019 in the New England Journal of Medicine. And this clinical practice guideline was developed for 9 procedures. And essentially, it was statewide, disseminated in the state of Michigan. And this is what we call an interrupted time series. And so we want to look at prescribing before the intervention or this clinical practice guideline comes out, and then prescribing after that intervention. And essentially, there were over 11,000 patients who got a prescription and gave some patient-reported data. And once this clinical practice guideline went in saying, okay, when patients have X procedure, they should have, no more than 10 tabs of oxycodone. And then, let's see if that addresses their pain, just for example. And so this clinical practice guideline came out to standardize the opioid prescription patterns. And what they found was that there was an 80% decrease in opioid prescriptions after this clinical practice guideline came out. And really at the bottom, what you see is that there were equivalent pain scores, right? So satisfaction was consistent across that time period, and pain scores didn't increase after the clinical practice guideline came out. And really, the big thing is that the opioid consumption decreased without impacting satisfaction or pain scores. And so thinking about how do we extrapolate this type of information into our maternity care, our perinatal and postpartum pain management was our next step. And so this is some updated and sort of forthcoming clinical practice guidelines, again, for patients undergoing a vaginal delivery or a cesarean birth. And so this was a study that was sponsored by the FDA to develop a comprehensive patient-centered clinical practice guideline for postpartum pain. And this was across populations and procedures, but will focus primarily on the special population of individuals with a substance use or opiate use disorder. And so just to give a little bit of background, there were several steps of this practice guideline that we went through. And so the first step was really looking at the literature and gathering what is sort of already known to put into the clinical practice guideline. Then the next step was to get a consensus panel. So these were experts from across the country in all, anesthesia, pain management, family medicine, obstetrics, across the several clinical, groups and disciplines to help inform the clinical practice guideline. And then the last step was to incorporate patient and provider interviews and lived experience to finalize the guidelines. And so for the first phase, there were several studies that were identified ultimately for vaginal births and cesarean births. And again, overall, 41 studies were identified for vaginal births that looked at pain management and 105 for cesarean births. Several of these were randomized, but again, not all in patients with substance use or opiate use disorder. And in terms of what the consensus panel was asked to do, specific for this patient population, was to look at complex pain subgroups. So these are, again, birthing people with an opiate use disorder or with chronic pain. And they were asked to look at the intervention, namely a prescription for that vaginal birth or cesarean birth. And then for this patient population, we again looked at existing recommendations, incorporated this sort of expert guidance, and then ultimately came up with some principles for management. Again, looking at the consensus panel, there were, again, MFMs, OBGYNs, nurse midwives, anesthesia, a plethora of folks that were included. And this consensus group was also supported by these different organizations. And so some of the recommendations that have come out of this consensus group um, were the following. So the clinical practice guidelines had several components, and this was for all patients. And so education and counseling. So we talked about sort of, patients who we have a high concern for, maybe considering Narcan, but making sure that we educate patients on the importance of that. Scheduling non-opioid medications, non-pharmacologic strategies. Some of the patients in that interview talked about some of those, sort of the hot compresses and the heating pads and things like that. Inpatient strategies, and again, tailoring the opioid prescription. And then the last thing was a principles-based approach for patients with opiate use disorder and complex pain. So I just wanted to talk a little bit about this group. Again, we wanted to think about this through a health equity lens, and keeping the patient centered when thinking about prescription sizes and recommendations. Management of individuals on long-term opioid therapy, as well as patients taking medication for opiate use disorder, was sort of the main thought in sort of the complex group. And again, some of those considerations that we talked about, including postpartum considerations. So when we think about the general principles, again, recognizing individual variation in the spectrum of opioid use. Um, Ideally, this would be established and seen through by a multidisciplinary team prior to admission, right? So the idea is to not have this plan put in place after the birth, but really to start thinking about this plan prenatally to understand whether the patient in front of you even wants an opioid prescription, if that person has a cesarean birth or undergoes surgery. Is that something that they would even want so that that can be documented? And if that's something that they're okay with, what other adjuncts would be feasible and appropriate for this patient? And if it's not set prior to admission, again, considering tapping into that team or a team like Max for Moms, if you need telehealth support or if you want the brain trust to help you think through what that pain plan should look like. And then using some shared decision making with the patient to think about, how much pain medication is necessary given the pain scores, and then what that prescription size should look like postpartum. For this patient population, again, patients with a substance use disorder, particularly opiate use disorder, irrespective of where they are in the pregnancy, should be offered medication for opiate use disorder. Um, Naltrexone is not considered first line. So typically things like methadone and buprenorphine we use first line. We certainly have patients that are on naltrexone for opiate use disorder, but it does require patients to be abstinent for a long period of time where the risk of relapse is high. We want to make sure that patients know to continue their buprenorphine or their methadone during the birthing hospitalization. And that dose is typically recommended to be split during pregnancy and to continue that. And to recognize that their medication for opiate use disorder is not pain management. And so that's something that we, you know, tell our patients and also tell other clinicians. And again, think about avoiding mixed agonist antagonists or full antagonists, again, like naltrexone, which may make it difficult to manage pain. And so thinking about some of the enhancements, some additional counseling. So again, making sure that patients are aware of the risk of overdose, the importance of treating pain, um, over and above what their standard methadone or buprenorphine dose is, making sure they're educated about the risk of withdrawal for those medications in the neonate, and how to sort of return to their usual opioid regimen, right? So they'll go home with the prescription. We want them to be maintained on their medication for opiate use disorder, but then ultimately they'll taper that prescription down and they'll be back to their home dose. And then offering things like naloxone, and making sure that patients are educated about that. So things that we can do in the hospital are offer things like extended release ketorolac or other sort of Motrin or ibuprofen-like medications for the first 24 to 48 hours, and sort of alternating those with things like Tylenol. This clinical practice guideline does take into the account that some patients can't have ketorolac or ibuprofen or can't have acetaminophen or Tylenol. And so there's some considerations for that patient population as well. Oh. And when we talk about tailoring opioid prescriptions, this was something that the consensus panel sort of came up with. So there was wide variation in many of the studies around size of prescription and whether a prescription should even be given. And in the Michigan study, there were large, across most of the hospitals, most of those hospitals gave a opioid prescription after a vaginal delivery. And when we looked at nationwide prescriptions after birth, we also saw a lot of prescriptions after vaginal delivery. And talking to this consensus panel, the recommendation was really that after a routine vaginal delivery, that no tablets of oxycodone or opioids should be given unless there's some sort of extenuating circumstances, right? So maybe a patient has had a third or fourth degree laceration and is having some difficulty with pain. Um, Maybe the patient has had a postpartum tubal ligation with a mini lap or mini laparotomy or incision on their abdomen, and maybe that might require a small course of opioids. Again, they thought patients who've had a cesarean birth, who are otherwise uncomplicated, should typically have 0 to 15 tabs. And again, this should be based on their use in the hospital. And then these are some of the other sort of indications. Maybe the patient needed a hysterectomy for some sort of reason. But at baseline, these were some of the consensus. This was from the consensus panel. And then on top of this, you want to layer in the patient in front of you, right? So this is taken into consideration the general population. When we looked at those prior studies, we know that patients with opiate use tended to require a little bit more opioid postpartum. And so again, looking at their use on day one, postpartum, day two, postpartum, and day three, postpartum, how do you, from a shared decision-making standpoint, agree to a prescription size? So some additional strategies, again, you want to confirm their existing opioid prescription with their prescribing provider. A lot of us use the PDMP where we can sort of look in the electronic health system, health record system, and see what that prior prescription looked like. If patients are going to a methadone clinic, we can certainly call and confirm the size of their prescription. We want to prioritize getting patients back to their pre-procedure regimen as soon as possible. And if an opioid is needed, again, thinking about what is needed and how long that interval is that we expect patients to have pain. Prescribe only the quantity that's likely to be used. And again, looking at day 1, 2, and 3 of postpartum, and really not exceeding 2 to 3 days in a prescription, and making sure that patients will sort of contact you if they're still having extensive pain or have short course follow-up, so that you can kind of evaluate the incision and how they're doing, and make sure that everything is going okay. The other best practice is to utilize immediate release and short-acting opioids, and again, to base the prescription size on the 24 hours prior to discharge. So non-pharmacologic strategies, these are just things that can be considered when possible, if things are available. So some of these things can be connecting patients to therapy, making sure that their mental health is considered in conjunction with their pain and their surgical recovery. Those things have been just recommended by the consensus panel. And then inpatient only strategies. These are some things that we can do on the inpatient side to, again, reduce the amount of opioids that we are prescribing. So thinking about long-acting neuraxyl opioids combined with NSAIDs and Tylenol or acetaminophen. Those are typically effective for pain relief. And so, a patient gets an epidural, they get sort of a long-acting medication in that epidural. And then hopefully with alternating the acetaminophen and NSAIDs, their pain can be pretty well controlled. Again, because some of the our patients have chronic pain, long-standing pain, or on-standing opioids, we can consider things like the transverse abdominis plane block or the TAPS block. Again, you want to talk to your anesthesia colleagues to see if who has expertise and who's available, perhaps for a scheduled section that you know is coming up for a patient with chronic pain or opiate use disorder. Thinking about PCAs, if that is necessary after a cesarean delivery. And then there are some studies have looked at things, alternatives like IV ketamine for severe pain. But again, those are sort of experimental. And again, we don't have a lot of evidence for some of those alternatives. And then lastly, some postpartum considerations. Just thinking about the whole patient and what their parenting goals are. We often want to consider whether they're planning to parent, and if they are, encouraging rooming in and breastfeeding. And, with their methadone and buprenorphine, in addition to any opioids that we're giving them for their pain control, breastfeeding is still recommended and supported. Counseling patients about the need to discontinue breastfeeding if there's return to non-prescription opioid use or a relapse, and then ensuring that patients have follow-up not only with their OBGYN or nurse midwife, but also with the clinicians caring for them from a mental health standpoint and for their substance use disorder. And so I just wanted to kind of go through a little bit of this and offer some time to answer some questions. Again, there's not a lot of data, randomized controlled trials, prospective studies, with regard to pain management for patients with substance use disorders, particularly opiate use disorders. We're kind of relegated to case reports and case series and some, retrospective cohort studies. Big things that we should know is just to continue the medication for opiate use disorder, including buprenorphine and methadone, but recognizing that those are not pain management. That's not for pain management, that's for their chronic medical condition. And to try to avoid full agonists or full antagonists, I'm sorry, that might impact pain management. Thinking about a multimodal approach. So we talked about having the epidural, and then also having sort of the alternating acetaminophen and NSAIDs when possible, and really sort of alternating those medications throughout the day to help with pain management. And can also consider some non-pharmacologic treatments, having peer support, having familiar or just a support person or a doula. Um, us showing as much empathy as we can because pain management in this population can be difficult. And then again, knowing that the short-acting opioids are the mainstay in that postpartum period. And as best we can, many states have a standing naloxone prescription at pharmacies across the state. Um, Otherwise, we can write a prescription for naloxone whenever we prescribe an opioid. And so that's kind of the best practice and making sure that patients and their support person know how to utilize the naloxone is important. Um, Again, a couple more thoughts, just patients are, presenting to us at a very vulnerable time and just making sure that we recognize that not only are we treating sort of the underlying chronic substance use or substance history, we're also need to have some thought about the intrapartum and postpartum pain management plan and connecting ourselves with colleagues or others who feel comfortable managing that pain in the postpartum period, having that prospective thought about, okay, what are we going to do for this patient when she comes in labor or when she comes for her C-section, sort of having that plan already in place. Um, and again, a plan is better than no plan. And again, there's not a lot of evidence, but I think it can be evidence informed. We want to avoid under treating pain because that really disrupts the trust and communication that we have with our patients. And I think if we get to a place where it's difficult, again, enlisting support from colleagues across the spectrum. We talked about all of those folks on the consensus panel, but also tapping into things like Max for Moms, where we can sort of give some guiding principles and some suggestions. And then again, addressing stigma and bias across all members of the care team will be important in managing pain for these patients. And again, more research is needed. I think there's a lot of space to do more in terms of research to understand how we can best approach pain for this patient population. And I just wanted to end with, again, the Maryland Addiction Consult Service, the Max for Moms line. It's free. Again, it's a phone call. Any clinical question you have, maybe you have someone who is going to have a C-section in a couple of weeks and you want to start to put a plan together. These are things that we frequently can help with and assist with and make recommendations around. Again, assistance with addiction and behavioral health resources as well. And having some of these collaborative conversations, I think, and hearing, how others have managed these issues and instances is helpful as well. And so with that, I wanted to just end and save some time for any questions.
Thank you so much, Dr. Townsell. As always, that is wonderful. We can still see your screen. I just was not sure if you knew that also.
Oh, okay, so should I
Um,
stop share? Okay.
there we go. Thank you. We did have one question that came into the chat already during your talk. It says, are there studies looking at increasing the buprenorphine doses for 3 to 7 days post cesarean section along with NSAIDs versus adding oxycodone, hydrocodone during the post-op period?
I'm not aware of kind of like a prospective, like a randomized control trial in that sense. I mean, I would not be shocked if folks have tried things like that anecdotally, but I'm not aware from colleagues or folks that that is something that has been extensively studied. I don't know if we have any of our other Max folks on the call.
I don't believe so,
Mhm. Yeah,
but
I don't think
follow
so.
up. If there are any other questions, please feel free to put it into the chat. You can also unmute yourself if you would like, and we certainly do have some time for questions.
Yeah, I think the other comment that I would make about that is frequently we have patients who want to come off of their medication for opiate use disorder. So they are sort of focused on, maintaining their dose and in the postpartum period, tapering their dose and coming off. And so, it could be a strategy for patients who aren't planning to taper to increase the dose, but I don't think we have like great evidence that that is managing their pain. Have folks found pain management in this patient population tricky, difficult? Have you reached out to colleagues for help? What have your experiences been?
You're welcome to unmute, or you can type in on whatever you would like in the chat as well.
Yeah, I will say a big thing for us is just if we have patients who are coming to prenatal care consistently, we typically have them, meet with our anesthesia team or have a consult with our anesthesia team to talk about, maybe their scheduled C-section and what our anesthesia team can offer. Whether they would want an opioid prescription postpartum or not. And then, some of that, Tylenol, NSAIDs, alternating some of those things and really trying to just talk through what that pain plan will look like. And then for some of our patients, again, many of them are multiparous and have had a baby before. We can talk to them about what worked or didn't work in their last pregnancy, and try to tailor their future postpartum pain plan to that. All right.
I know we still have just a few minutes, so I'm happy to kind of go over again some housekeeping items and the credit for today. So in order to receive CME or CEU credit, everyone would need to be enrolled in the course through Oasis. Um, so if you haven't already done so and you do want to receive credit, you do need to go in and you need to create an account through your Oasis portal, and then you can enroll in today's course, and that way you can access the evaluation and then download your certificate. Um, we are currently now live. We are confirming everyone's attendance in Oasis. So you'll be able to go into your portal immediately at the end of today to do that evaluation. You do need to do it within 7 days from today. So it will close after 1 week. Um, if you have any questions, you can definitely contact us at Max for Moms. And again, just to echo what Dr. Townsell was saying, that if you have any clinical questions, you can contact our consultation warm line at any time, and our team is happy to help. If you think of some other questions after today, after the webinar, you thought, I wish I had asked this or that, you can contact us at any time, and our behavioral health consultant can connect you with Dr. Townsell or another member of our mom's team, and we're happy to help. So I don't know, Dr. Townsell, if you wanted to hang on for just a few extra minutes in case anyone thinks of questions afterwards, or if you have any of questions about housekeeping, the credit process, I'm also happy to help, but I can keep it open for a few more minutes.
Okay. Yeah, I think the only other thing I would share is just we have colleagues across the country who are caring for patients, and every hospital system or hospital has their own um, you sort of pain pathway or order set. And so I think, certainly if there's a question of how to approach this from a system standpoint, we can give some pointers about that. And then I think individual patients we could also talk about. So however we could support folks.
Thank you.
All right, thank you.
Well, I hope everyone has a great rest of your day. I'm happy to stay on for another minute if anyone has any questions about Oasis, portal, housekeeping items. Um, but you are free to go, and I hope everyone has a great rest of your day.